So let's talk about life pre GLP-1s as a
Yeah.
practicing obesity
Yeah.
specialist and life post.
Yeah. So I went to med school late 2000, so 2007. That's right when these drugs started coming out. Byetta was the first one, exenatide, but it was for type 2 diabetes. It wasn't on the radar to use these for weight loss. At the time, people were really focusing on basically phentermine, a
Yeah.
noradrenergic sympathomimetic drug. It has amphetamine-like properties, but not addictive. A little bit of an upper, but yeah, noradrenaline, noradrenergic, and that was like basically what people used. I started going early on to obesity medicine conferences, and it was there was some weird stuff that they were promoting. And you got HCG and all sorts of stuff that people were trying to use HCG diets, but a lot of phentermine. And if people remember phentermine was one of the components in fen, but it was not the bad component. Fenfluramine was the one that caused heart valve issues. And so they took that one off the market, but kept phentermine around. It had been around since the 1950s. So once I got to residency, which was 2011, right in 2012, Qsymia was approved. And that is a combination of phentermine and topiramate. Topiramate works in GABA. They think that's part of why it works for appetite suppression. But think about different receptors, lower doses of each, so you get fewer side effects. The phentermine can cause people to have insomnia, dry mouth, heart palpitations. So you try to use lower doses and then add it to something else that has a little bit of a appetite suppression, which is topiramate. Doesn't work in the same pathway. So that was approved, and that was for chronic weight. And that got, the highest dose gets around 10% total body weight loss. So not bad, but side effects. The other one was, if you remember, lorcaserin with Belviq. Um, it is actually similar to fenfluramine, but it had a different serotonergic receptor, more specific. Actually got taken off because of, we don't know why exactly, but some concerns for cancer. Very mild weight loss effect, though, around like 5 or something percent total body weight loss. There was Contrave that came out in 2014, bupropion naltrexone combination. Not that great, still out right now, 6%, maybe 5-6% total body weight loss. And when you think about like good diet and exercise, intensive coaching, you're going to get around 5 or 6% total body weight loss on average. People are like listening, going, "I lost 100 pounds." And it's like, yeah. I'm saying on a population average, we're looking at that number. So Contrave or bupropion naltrexone wasn't that great. So it was very frustrating. In residency, I'm like, oh, I'm going to be an obesity doctor. I'm trying, trying to do my thing. And those are the drugs that I had. It was 2014. I believe it was Saxenda, liraglutide, if people remember Victoza. So liraglutide was the second GLP-1 receptor agonist that came out in like whatever it was, 2009 or something for type 2 diabetes. But 2014, they cranked the dose up to 3 milligrams. Now, liraglutide is a once daily injection. And that high dose liraglutide in 2014, they promoted as Saxenda, was around like 7 or 8% total body weight loss. So like, it's okay, but it's like a $1,200, $1,000 drug for more side effects, daily injections, and overall not that great amount of weight loss. So that was like we went from lifestyle, trying behavior with some high side effect drugs that some people responded to. And then you jump all the way from that to bariatric surgery that, do you get 30 to 40% or more total body weight loss? Pretty drastic. People are like, "Oh God, I got to get surgery." It's like, great. So that's why in 2021, when semaglutide, Wegovy was approved at that 15% total body weight loss, things changed so much. That's why everybody's like, it's a game changer. Because like we were really limited in how we helped people. It was like resources for intensive coaching. That takes a lot to get people. And then it's very frustrating because everybody says they know what they do. I mean, my patients aren't idiots. Some people are, like some people are idiots. They don't know what to eat. I remember a patient, I was like, here, let's try to eat more protein, whatever. And they came back and they're like, I don't know, I'm eating more protein, but I can't lose weight. And I was like, well, tell me what you're eating. And they're eating a bunch of spare ribs. And I'm not saying this person is idiot, but it was clear, even though I gave a list of the foods, like spare ribs, that was what they were eating for protein. And it was, along with a bunch of other things. But most people understand that, hey, I should probably eat more broccoli instead of French fries. Like, it's
Yeah.
just very, like, just
Basics.
very, very, most people have that. And a lot of these people have been trying for their whole life. And so, like, for them to come to a weight loss doctor, specialist, obesity specialist, and me basically going, okay, here's what we need to do. I got these other drugs that maybe you're not going to tolerate, but like, let's really focus on these behaviors. They're like, I already know these things. It was very frustrating from a doctor's standpoint, a clinician standpoint, and then also from a patient standpoint. It's like, so that's why they go and get the $300 a month detox from someone online or whatever that promises to rid them of their fat, and then they lose all their money doing that, and then it's just very frustrating. So that was what it looked like before these drugs.
Yeah. So complete game changer
Yeah,
because
yeah,
these peptides put the onus of control back in the driver's seat and they induce neuroplasticity.